one of the most divisive policies to come out of the pandemic was the mandatory masking. This was a policy that was never enacted before because all the randomized controlled trial studies leading up to COVID showed that masks were largely ineffective, didn't stop the spread of viruses like influenza, for example. And so they were never implemented. Suddenly COVID came, and I think public health officials needed something. They needed to give people that were afraid something to empower them. And so masks became that thing. And even though knowing that they didn't work, I mean, if you remember some of Fauci's earliest statements that became public, it was clear that he understood that masks didn't work. So when we start digging into the literature, we see a couple things. Obviously, number one is that many of the most important studies clearly show that masks don't work. So the Bangladesh mask study is a classic example. This is the largest masked randomized controlled trial study conducted. There's about 340,000 participants in this, and these were individuals in Bangladeshi villages. So they compared medical masks and cloth masks to no mask, basically. So in one arm of the trial, there was 190 pairs of villages, and about 103,000 individuals were in the control group. That is, they were told basically not to wear masks. They weren't given masks. They just kind of did whatever they wanted. So no mask mandate, essentially. And then in this arm of the trial, N sub T, it was about 113,000 individuals that were given masks and given instructions on how to use them and encouraged to wear them. So not all of them wore them. I think it was ended up being about 40-something% of the population wore them. And here it was maybe about 10%. So in the end, I mean, that's a huge sample size. And in the end, if masks really mattered, you should see a signal. And basically, here are the results. I should back up and say what they were looking for was symptomatic and seropositive individuals. So they basically, asked individuals to volunteer this information after the 2-month trial. Were you symptomatic and were you seropositive? And then they would record that information. So in the control group, there were 774 symptomatic and seropositive individuals. This was, again, the low mask wearing group, the 10% or so. And this is the so-called treatment group, where 756 symptomatic and seropositive individuals were in the treatment group. So again, this is a difference of 18 individuals out of well over 200,000 participants. This is well within the margin of error. There are a couple issues as well. The participants that were volunteering to give the results, and far fewer, at least 1,000 fewer individuals in the mask group volunteered than in the control group to provide this symptomatic seropositive individual. So in a difference of 1,000 participants, it's really easy to imagine numbers this low getting swallowed up. In the cloth mask group, there was 96 pairs of villages. In the control group, again, the group not encouraged to wear masks, nearly 54,000 individuals, and here's the treatment group, nearly 57,000 individuals. The difference in here, though, the control group had 332 symptomatic and seropositive individuals, while the testing group, the treatment group, had 330. So that's a difference of 2. So out of about 340,000 individuals, you have a difference of about 20 that were symptomatic and seropositive in the group that wasn't wearing masks. That's a very, very low signal that, again, it's not statistically significant given the population size here. And given the fact, like I told you, that participants volunteered to give results and that far fewer in the mask group, thousands fewer, at least 1,000 fewer in the mask group volunteered than in the control group. But another aspect of what I wanted to say here is that a lot of individuals overblew these results. So, and this came from the prestigious journal Nature. The study's authors found that surgical masks, but not cloth masks, reduce transmission of SARS-CoV-2 in villages, where the research team distributed face masks and promoted their use. So let's look at that. They're saying that this is a resounding success. 18 individuals out of well over 200,000, and again, easily could have been swallowed up by the difficulties or the inconsistencies in the experimental design. And the cloth masks, at least they were honest enough to say that a difference of 2 individuals is not significant. But the point also is that the authors of this paper never gave you this information. This information was actually gotten by an individual professor at Berkeley, and I found this in one of the pieces that he had written. So these absolute numbers were simply manipulated, and the end result was that medical masks reduced, according to the authors, medical masks reduced symptomatic seropositivity by 10% or something like that. And Nature, a journal that should know better, declared that a resounding success. And again, when you look at the raw numbers, these are not successful numbers. When we take a look at just a simple comparison of mask-mandated states versus no mask-mandated states, here's, in this particular case, on the y-axis, daily new COVID-19 cases per 100,000, the no mandate states versus the mandate states. There's really no difference other than here, the mandate states had a little bit of a decrease, but overall there's really no difference. And so again, the commotion and just divisiveness that policy caused clearly isn't worth it. And this was just a piece from regular newspaper article. Eric King at the San Francisco Gate. Do mask mandates work? Bay Area COVID study says no. And when I look at, I was doing a lot of wastewater analysis. And so when you look at just data from my wastewater analysis, and again, this is a way to test for the virus spread in the community, just using wastewater without having to rely on people to show up to a testing facility. So this orange line here is the change in virus load per liter of wastewater over time. And here you see, one of the big Omicron bursts. And then over here is a second Omicron burst and so forth. This is a Delta wave. But what I wanted to show you is that between this peak, or between this date and this date, was when the SLO County mask mandate was in place. And that did nothing to stop this really strong Omicron wave. So a lot of people would say, in criticism of the Bangladesh study, for example, what if we mandated more people than 40% to wear masks? Then we would see a signal. And I refute that by showing New York City, for example. Here's, in this instance, coercive policy did not improve health outcomes. This was the first wave in New York City in April. The mask mandate was put in right here. So this was totally endured without a mask mandate. Then the mask mandate went in here while it was already plummeting. So what they did in New York City was implemented mask fines. Even though mask wearing was super high, they implemented mask fines right here. And that did not stop them from getting crushed by this bigger and longer wave. So the question that I would ask is, does coercive policy actually make a difference? And at least in the case of New York City, no. Another important study further emphasizes my point. This is from a Cochrane review. And Cochrane is a leading resource for evidence-based medicine. Nobody's ever really refuted Cochrane until this mask study came out just recently. And so, again, the title is Physical Interventions to Interrupt or Reduce the Spread of Respiratory Viruses by Jefferson et al. And so what they show here in the summary of findings are medical surgical masks, and they're showing, risk ratios here and number of participants. So they basically took 9 randomized controlled trial studies representing nearly 276,000 individuals, and then looked at the ratio of individuals wearing masks that had COVID-like illness divided by the ratio of individuals not wearing masks that got these COVID-like symptoms. Similarly here, this is laboratory confirmed. So again, they're risk ratios. And so in this instance, a 1-to-1 ratio means that there was no difference between masked and unmasked cohorts. This is 6 randomized controlled trial studies representing nearly 14,000 individuals. In this case, this number suggests that masks had about a 5% benefit to the population in preventing COVID-like illness. But look at the confidence interval is pretty wide. So it's anywhere from a 16% benefit to a 10% or 9% detriment. So again, these are relatively inconclusive, especially given the size of this study. You couldn't go out and tell me that masks work. You couldn't go out and tell me that masks work based on these numbers. Especially here, and this is laboratory confirmed influenza or SARS-CoV-2. And again, with a risk ratio of 1, look at the swing though. So now you're saying, masks worked 28% of the time to they failed 42% of the time. That's a huge swing. So again, the final number suggests that masks really don't make a difference. And again, these study sizes are significant. This is another one, but this is actually with N95 respirators, which is quite surprising. Here's, again, I'll focus on laboratory confirmed influenza. And so, again, many of these studies were done prior to COVID. And so, again, when you look at the risk ratio, it's actually 10% detrimental. The individuals wearing masks were 10% more likely to get COVID than individuals wearing masks. The swing is pretty wide as well, but it's, masks help 10% of the time to hurt 34% of the time. And you can see that across the board that these swings are really wide. Even though in this case it looks like, masks worked, protected people 30% of the time, but look at that pretty incredible swing in these randomized controlled trial studies. Again, the numbers suggest that they're all over the place, and you can't confidently say that even N95 respirators stop infections by respiratory viruses. For me, one of the earliest signs that there was something wrong, that the science was being politicized, was in the prevention and treatment, in the treatment section of the COVID response. And so here it was very clear that the policy was very designed for pushing everybody into hiding and locking down and waiting for a vaccine. And to me, that suggested greed, because there were things that could help. And vitamin D was one of those things. There were some studies that suggested that it might counteract the pro-inflammatory response. Not just vitamin D, but other anti-inflammatories too, like dexamethasone and so forth. The mechanism here was that 125 dihydroxyvitamin D would interfere with the NF-kappa B pathway, which would minimize tumor necrosis factor alpha and interleukin-6, these pro-inflammatory cytokines. And so there was a mechanism, and there is evidence that vitamin D could have been helpful, probably in combination with other things. The anti-inflammatories, many doctors are using budesonide and dexamethasone and glucocorticoids to minimize the inflammatory response as well. There was a clear bias towards the antivirals, though, especially the expensive ones like remdesivir at $3,000 a treatment. Paxlovid as well. Remdesivir interferes with the polymerase that the virus needs to transcribe its RNA, and Paxlovid interferes with proteolysis, to mature those polyproteins that I'd mentioned in a previous lecture. But there was also these cheaper ones that became very divisive, ivermectin and hydroxychloroquine. They got linked to a certain unfavorable political character, and there was no way for these drugs to receive fair treatment in randomized controlled trial studies. There was also a lot of monoclonal antibody therapy that was being worked on, and vaccines as well. And I'll get to the emphasis on the vaccines a little bit towards the end. But here's a little bit about remdesivir. As I mentioned, it's a prodrug, and then in your body, it's processed to an active molecule. And so the active molecule interferes with RNA polymerase and therefore inhibits RNA replication. And I will say this as a really good example of bias, the the drug is still standard of care, and you're not going to lose your job if you talk about it or prescribe it, even though evidence, this is from Medscape, evidence such as this came out fairly early on. The large remdesivir study finds no COVID-19 survival benefit with remdesivir. So this is a little bit about hydroxychloroquine and zinc, and so I knew several individuals that had been using this combination, high doses of zinc and hydroxychloroquine. The zinc was the actual antimicrobial in this scenario, where hydroxychloroquine was an ionophore, allowing zinc to enter and then interfere with the RNA-dependent RNA polymerase of COVID. And zinc also appeared to interfere with the spike protein binding to ACE2 and possibly even interfering with the furin cleavage of the spike protein, so the virus couldn't readily get in. So again, a combination of drugs, hydroxychloroquine and zinc, in combination with several others, was being used. But if you had talked about these things, you were automatically branded and even censored or fired in some cases.